Let me introduce myself. My name is Byron Bear. I am a geriatric internist as well as a geriatric psychiatrist, and work at the VA in the Veterans Rural Health Resource Center, Western Region, as director. I am also a professor of geriatric internal medicine and geriatric psychiatry at the University of Utah School of Medicine.
Hi, folks. My name is Cynthia Tyler. I am currently regional counsel for the New England area, and in my past life, I was a registered nurse with a background in mental health and risk management and hospital administration. So broadly, between the two of us, we have hopefully had enough experiences in these areas to give you an overview, and then what we are certainly hoping is to open it up as soon as possible, because with this many people, certainly there are going to be more questions, and there's going to be an opportunity for all of you to tell us what the real issues are, rather than have us presume to know them. Dr. Bear?
Thank you. I think we can have some vigorous discussion, so we'll get into some of the definitions and talk a little bit about some of the nuances, and then hopefully get in right to the discussion portion. Cindy, do you want to go ahead with our slide number 3?
Sure. I will assume that folks have the slides. I am, at this point, feeling technologically concerned about what's going on any number of levels, but we have pared down our intended discussion to just 13 slides. And what our committee decided when we first got together was that the idea of competency and capacity, the notions of how you think about these things, have really been very nicely articulated in a VHA handbook, a large handbook. And so I would commend that handbook to all of you. If you're not sitting here with it, at some point put it on your desktop, access it. It is the VHA Handbook on Informed Consent, and it is number 1004.01. Relying on that handbook, we want to go first to the definitions of competency and capacity, how we use them in the VA, and then what we are hoping to do is, having established what all these definitions are, to talk about it's not that easy. Just the fact that we know what the definitions are, then what happens every day when we have to go out and apply that in real life, and what kind of challenges they are posing us when we're dealing with patients. And Dr. Bear will talk about some of the decision-making issues and how clinicians think about those, how clinicians think about making these determinations. And then I will put on my lawyer hat and hopefully not be terribly provocative, but certainly raise the issue of what the courts would think and how legal folks think about these kinds of issues. Dr. Bear and I have had opportunity to chuckle at the fact that it's highly unlikely we can get through an hour of a medical and legal perspective without disagreeing over something, and if we don't manage to do that on our own, I would assume that will probably flow from some of your questions. But for the most part, it is important that we find a way not to be at odds on these issues. Competency and capacity are words that are used interchangeably in our facilities and ought not to be, and that's one of the first things that you can look to the handbook for. The handbook definition first of competency. Competency is a legal determination. When we talk about somebody not being competent, it means that a court made a determination that that person is legally deemed to be incapable of making decisions. And it's important to keep in mind that folks can be deemed incompetent by a court and still be out there in the world functioning. An incompetent person may well be in our outpatient system as well as in our inpatient system. In contrast, decision-making capacity, talking about whether or not somebody has capacity, is viewed as a clinical determination. It's based on a clinician's assessment of whether that person can take in what's going on around them and they are able to make decisions about the things that are deemed to be important for them. So the distinction, competency and capacity, will come up over and over again throughout our comments and certainly throughout your practice. If a court determines that somebody is legally incompetent, then the court will appoint a legal guardian. And it's at that point that it's not quite as easy to simply look to VHA handbooks and VHA written guidance, because once we invite ourselves as a federal system that frequently claims supremacy and says we really don't need state courts, once we invite ourselves into the courts in these situations, we are bound by state law. So that the notion of each individual state having different terminology is one that you need to pay attention to. In some states, people will be talking about guardians. They will be talking about conservators. It is important to know in the state in which you practice what language applies, what those things mean. They are terms of art to a court. Even in New England, it's very different for us. A conservator in Connecticut is not necessarily legally intended to mean. That term doesn't mean the same thing as it does in some of our Massachusetts facilities because of the state law differences. So it's important for you to know that in your own practice. The other sort of important facet of this piece is that the VA has over the years sanctioned a use of the word competency in a way that really kind of takes it away from the court. The VA will deem someone to be incompetent. The VA having deemed someone thus means that they're not going to be able to handle their own benefits. It's a benefits determination, but it does not hold sway in a legal kind of setting. It does not mean the person has been legally determined to be incompetent. It means VBA said that they are incompetent to handle funds. So those are the critical definitions that you need to keep in mind as we head through this discussion and as you all head through your practice. The different states will also, and over time, we are moving ever more in a direction where even with the state variations, you will see more of this. But it used to be if someone was, whatever the state called them, whether that be a guardian, whether it be a conservator, their duties were clearly defined under the law. A conservator of the person had certain duties designated to them by law that had to do with end-of-life decisions, feeding tubes, those kinds of things that were healthcare driven. And a conservator of a state, by contrast, or a guardian of a state, dealt with issues that were financial in nature. They would be the folks who would make determinations about checking accounts and where money was spent and paying for rent, those kinds of things. But they were just broadly defined as the rights designated by law. And what has happened over the years, as folks have paid more and more attention to people's civil rights, it is presumed that even when someone is legally, quote-unquote, incompetent and in need of a guardian for whatever purposes, those guardianships should be as limited as they can possibly be. So that the courts in most states now designate not just that someone is a guardian for purposes of estate management or a guardian for purposes of personal decision-making, but they will very specifically define that person's duty. So in many instances, for example, you will have a patient who can make some amount of financial decisions on their own, even if a court has deemed them incompetent. Their conservator, their guardian, their court-designated surrogate only makes decisions, funding decisions in excess of, say, a set amount of money, or only makes decisions related to major surgery but not everyday medical decision-making, those kinds of things. So it's important to look to the documents. And so when we get calls in our office that a clinician has a patient who has a family member who is a guardian, a conservator, we will typically be reminding people to get your hands on that document and understand specifically what it is the court has designated this person has authority to do. And we will talk about those kind of designations that we ought to be making even when we talk about people who are surrogates. We ought to be able to speak in the medical record about somebody's abilities. So our ability to speak about their abilities is what Dr. Baer will be telling us more about in the next portion of the program. Byron?
Thank you, Cindy. These are such important concepts. Surprisingly enough, they've actually done research on how physicians and lawyers view things differently. And I think it's an honor to be able to speak with lawyers, to really look at the multidimensionality of this issue. It's interesting when we talk a little bit about surrogacy that it's been found in some cases that actually person has capacity. And certainly, if they've not been deemed incompetent, relying on surrogacy is not appropriate. So looking at how a person, or determining whether they have decision-making capacity is actually very important from the individual perspective. And if you'll go to slide number 5, listed on slide number 5 are some mental skills that are needed to function on a daily basis. Now, the reason to talk about these is because these do affect a person's ability to make an informed decision. And as you can imagine, there's lots of situations that informed decision-making could be impacted. Certainly illnesses and medications can do that, but also I think it's important to note that life situations can change someone's ability to function in life. Grief, for example. Acute grief may incapacitate someone. So depending upon the day and the situation, your function may vary. And similarly, your ability to make informed decisions might also vary. One of the things I think it's important to understand as well is that how do we test these functions? And oftentimes it's by asking questions, and there are some tests that have been done or testing methodologies, but it's really dependent upon the day or the tester on how that comes out. So there's lots of variabilities. So as we look at some of these functions that may impact decision-making capacity, we'll try to look at some of the clinical correlates. The first is executive function, and this doesn't mean how your boss functions. This is actually how your brain describes the set of cognitive abilities that control and regulate a person's abilities and behaviors. It's necessary for goal-directed behavior and includes such things as abstract thinking, planning, modulating your behavior and emotions, and your ability to think abstractly. In a clinical sense, we think of oftentimes of these as instrumental daily activities. For instance, how you are able to manage your money. Are you able to manage your medications? Are you able to arrange your self-transportation, whether you're driving yourself or arranging that? Are you able to acquire things via shopping? Are you able to prepare your meals? All of these can affect your ability to function in those executive functions. And if those are impairments, there are impairments in those areas, it very well may be a clue that we need to look at someone's ability to make informed decisions. When I look at older individuals, and the same could be applied to very young individuals, if they have difficulty managing their medications, for instance, that might raise a red flag. Do they have some impairments that need to be further investigated to see if they do, in fact, impair their decision-making capacity? It's very important to know, though, that these disabilities individually in executive function may not impair your capacity. So it requires further intervention and testing and investigation to see if that is actually true. Memory is next listed, and memory is an important skill or function to be able to have a continuity in what's going on. And we'll talk a little bit about the standards of how to proceed. But if you can't remember what you wanted yesterday and it's a brand new day today, or even in 5 minutes or an hour, it's very hard to be able to take the information, to make an informed decision, and process that information in a way that you can make a decision. So memory is a critical part of that, and language is also important. Not only the spoken language to be able to communicate a decision, but also the capacity of language to understand it and to process the meaning. And oftentimes as healthcare professionals, the comprehension of language may not be the problem of the patient per se. It may be how we're using language ourselves. And it's very important, I think, as we educate in that informed piece of informed decision-making capacity, as we inform patients, to make sure we're using language and relevant information that they can understand and avoid jargon and long discussions about scientific principles that, while they may be valid, may not be easily comprehended. So the language is not only something that the patient has to have, but we need to look at ourselves and make sure we're using the language that's appropriate for the age of the individual, their social situation, and also their cultural background. The next item is the ability to be flexible in managing more than one task at a time. And I'm sure you can all think of individual instances where we are, as individuals, decisions. And so looking at how people are able to manage those activities, they don't have to be complex activities, but that may also impair their ability to make informed decisions. Now, if someone has impaired cognitive skills, which comprise these daily functions, that may adversely affect their capacity. But interestingly enough, scales that look at just cognition, such as the mini mental status exam, may not correlate very well with decision-making capacity. There's been some literature that it's really the extreme scores before it really affects capacity. So it's very hard to use scales that have been used just for assessing cognition and then try to translate that into decision-making capacity. So that's an error clinically that we probably should not make, is say because this person has thus and such a score, they are not able to have decision-making capacity. For instance, in one small study of about 45 patients, it was found that you had to have an MMSE score of less than 20 for that to affect your decision-making capacity, but even at that, it wasn't 100%. What they found was scores of 20 to 24 had no bearing on decision-making capacity. And so as an example, it's important while we look at cognitive functions, we really need to go deeper into how that daily function occurs for that individual to understand that impact on decision-making capacity. If we go to slide number 6 and start talking a little bit about the 4 components of decision-making capacity, and I would insert on this informed decision-making capacity because it's very important to make sure that the patient has been informed before we assess their decision-making capacity. And we can't assume because they may not understand their medications that they don't understand it. We have to make sure that they have been educated about those medications or their medical illnesses. And I think that's a very important point to make sure that they have informed decision-making capacity. So looking at the first component, understanding. If you look at that slide, the definition there is looking at the person is not only able to indicate their choice, but also to understand the information presented regarding their treatment. Understanding can be demonstrated by the person's ability to paraphrase what has been told to them regarding the diagnosis, to recommend treatment, and to look at the risks and benefits and alternatives to treatment. Oftentimes, this understanding can start very simply by questions such as, what have your healthcare providers told you in terms of your diagnosis or your medical condition? And start a dialogue about what they understand about what the healthcare professionals have told them about their illnesses and what needs to be done. Oftentimes, putting that in terms of their own language might be important. So understanding diabetes type 2 may not be that same word. You may use a word that would maybe be similar to, do you have sugar? In different cultures and socioeconomic status, that may be an equivalent. And so it's important to make sure that they understand what is being said and that also we're communicating in a way that is understandable. Next decision-making capacity component here is appreciating. This is a little bit higher legal standard than just understanding. It's actually the ability of the person to relate to the information, relate that information to their own circumstances. And this includes having insight into and acceptance of the illness. And I put that in parentheses. It doesn't mean they accept the illness as they understand it from what you said and able to process that information and really understanding the implications of their decisions. So they really are able to understand about this. And so questions might be based on what your understanding of your illnesses are, what kind of treatments have been suggested, and why do they want you to take insulin, for example, and what might be the impact for you to take that insulin or not. If we go to slide number 7, the third component here, which is, again, a progressive standard of being able to manipulate information, is how would you formulate that information and then manipulate that in a rational way to really be able to focus on the thought process applied by the person to derive at their decision. This ability is really intricately related to one's understanding and appreciation. So one of the things clinically that we like to have are very separate categories, and here you can start to see that this is more of a scale might be even increasing difficulty in how to manipulate this information. For instance, in formulating and manipulating the information in a rational way, you could ask them about, using diabetes as an example, what happens with your diabetes in your everyday life? How would you like to be treated? And is this medication helping you achieve what you want to be, your goals are for your treatment? And how would they manipulate that information? The next step is being able to communicate this information. And this component may be the least stringent of the four components, but the person still has the ability to reach a decision and express that choice themselves. However, if someone's so indecisive to the point where their decision cannot be reached and they go back and forth, they don't have decision-making capacity. Generally speaking, we think that patients must have all four levels in order to have decision-making capacity. An inability on any one of these levels impairs their decision-making capacity to make informed decisions. So one of the examples I use in terms of communication is when I take my daughters into a shoe store, they're not able to decide between the 5 or 6 different pairs that they would like. In that instance, in that situation, they have impaired decision-making capacity. They're not able to make a decision, and oftentimes it requires a surrogate decision maker to help them. Now, one of the other elements of complexity here is that it may depend upon the risks and benefits of individual treatments. So if a risk is relatively low with the treatment and the benefit is high, that may be a relatively simple decision to make. However, there are degrees of risk, and if something's relatively high risk and the benefit may be uncertain, that interjects a little bit more difficulty into this informed decision-making capacity and might be a little bit more difficult to arrive at, and quite frankly, may be open to a variety of interpretations from a variety of different points of view. And so I think it's important to recognize, while we've kind of been very concrete in these examples, that even within these four components, depending upon the disease and the risks involved and the benefits involved, there could be a wide variety of decisions that could be made based on that information that might be rational given that person's individual set of information and how they interpret that information. So, Susan, Cynthia, do you have any comments or?
Yeah, well, I was struck by the fact that you are emphasizing how they process it, and that is so important for us to really pay attention, because you didn't specifically address this, but what we bring to any one of those conversations with a patient is our values, our experiences, and unfortunately sometimes our level of expertise. So we may be expecting an intellectual capacity that may not necessarily be there. We may be presuming things about values that are based on how we live and based on our lifestyle that don't fit with the patient's lifestyle and are not part of their value system. So it's just, again, while you are helping to make these assessments, or while you are presuming to make these assessments, I should say, you need to recognize that it is the ultimate in judgment. You know, our parents told us, don't be judgmental. You really need to pay attention that when you are making these judgments, you are making them through the right prism, that you're paying attention to who this person is.
You know, I really think that's a very important point, and what I'd like to emphasize is that we're really looking, when we do a determination of decision-making capacity, is about the process of making the decision. The actual decision is really not the focus of this determination. Whether it's yes or no, I don't want to do this, or I do want to do this, we're really trying to evaluate how that individual is processing that information to arrive at their decision. We're not trying to sway them any way. And clinically, sometimes that seems a little foreign to us because we may have those preconceptions as this is what I want to do. But I think really looking at this in this instance is how are we evaluating the process of making a decision is really the key component.
Well, I think in the ultimate sort of ugly experience in that regard would be the phone call, and I still actually get these, the phone calls from a clinician where I am told that there is a patient who no longer lacks capacity and for whom we need to run into court and have some kind of emergency decision maker appointed. Well, really, what are the circumstances? Tell me about it. Well, because the patient needs X treatment and he or she is refusing. And that's sort of the ultimate, well, gee, the fact that they don't agree with you probably doesn't de facto mean that they lack capacity.
And the corollary of that is very interesting because as clinicians, sometimes we think that as long as a patient agrees with us, then obviously they're competent. The only time we call into question their ability to make decisions or their capacity is actually when they disagree with us. And there was a very interesting study done out of Walter Reed where when they asked and they looked at patients who did and did not have capacity by interview gold standard, they found that it was only recognized by clinicians 42% of the time when actual patients did not have capacity. So here were patients who did not have capacity. Out of 100% of those patients, only 42% of those patients who did not have capacity were actually identified by clinicians. And I think it's because if they agree with us, obviously they have capacity.
You're out of your mind, but you agree with me, so it's all good.
So I think that puts us on to slide number 8.
Thank you, Byron. I wanted to go back. I am, at this point, charged to pick up on the issue of surrogacy and talk about what we can do in the VA once we have made that determination that somebody lacks capacity. But before we do that, I wanted to go back. Dr. Baer made an interesting comment at the beginning of this portion of the program where he said we need to be careful about relying on surrogacy. And I like it as a phrase because for me, it makes me think of one of my favorite, Monty Python movies where the poor guy was saying, but I'm not dead yet, as they're carting him off. I have seen us get so extreme on issues of surrogacy that we wind up with circumstances, well, the wife is at the bedside and she wants the patient to have a full code. And the patient is in the bed saying, hello, no, I have already signed a DNR and I don't want it. And if my, heart stops working, I do not want it. And I get called and told that we have a legal issue. Well, quite frankly, we don't have a legal issue. And the piece that we need to keep in mind is that the patient who has capacity is the decision maker, so that none of our policies, our 31-page handbook, none of these documents are intended to suggest that there is a situation in which democracy rules out. So if it's a spouse and 4 children at the bedside and they all feel really strongly about something, they all get to outvote the patient. That's not how it works. So keep that in mind. And unfortunately, that is sometimes the way I see folks relying on surrogacy. I have also heard folks saying, I have the piece of paper, so I get to decide. Well, no, the piece of paper really only works if that person is deemed to be incapable. So with that little soapbox aside, let me go back to surrogacy. I wanted to start this portion of the program by posing a question to you. Once we have made the decision, once we have looked to some of the issues that Dr. Baer demonstrated to us, and we make the decision that this person lacks capacity, does this mean we have to go to court now and get a legal guardian appointed? The answer most often to that is no. And it is important from a clinical perspective to keep that in mind, that our VHA handbook provides a tool for us to be able to make an assessment of a patient, makes a determination, clearly document in the record that we have made that determination, and then clearly document in the record that based on that determination, this is who we have now designated, and we give ourselves the authority to make that designation. So, again, before we get there, keep in mind everyone is presumed to have decision-making capacity. The fact that a patient disagrees with us doesn't mean that he or she lacks capacity. Capacity or decision-making abilities can change rapidly. This is a big one, and it's a big one that we get called in on. You have the evening shift, and then you have the day shift, and you have a bunch of notes now in the record where half the staff thinks that the patient is incapable of decision-making and the other half thinks the patient is capable, and that gets presented to someone in one of my offices as a legal problem. I would posit to you that that's not a legal problem, that's a clinical problem. The fact that we keep creating records that are increasingly suggesting that we can't come to some kind of clinical agreement on the patient's mental status concerns me from a decision-making level, and it concerns me at a legal level with what kind of documents we're creating. But that, frankly, is not a legal issue. It's a time for the treatment team to get together and try to come to terms with what it is that is making this determination so difficult, or, in fact, is it somebody whose mental status is waxing and waning so quickly that really it's not that anybody is wrong, it's that you really need to capture what's going on at the time that you are creating that record or trying to make the decision. The other one to keep in mind is once we have made that decision, once we have clearly indicated in the record that this is somebody who we believe does not have capacity, and it is someone for whom we now have a surrogate, we have a child, we have a spouse, we have the next door neighbor. It really, and it's spelled out in the handbook, how you can go down the line and determine who ought to be the designee in these situations. But once you've made that designation, you cannot and should not, and I implore you not, to then give the patient a signed, informed consent document for that colonoscopy you've been wanting to do. We do that, and then it looks bad legally. It also looks clinically like we don't really know what we're doing, or that sometimes we are willing to cut corners, and even though we thought the patient didn't have decision-making capacity, we decided that for our purposes we really needed this consent signed, so they really do understand that today. That's just not good decision-making, or from a legal standpoint, it's problematic in terms of the records we create. So keep those things in mind. Look to the handbook to find out the order in which you make these kind of designations. When you no longer believe the person lacks capacity, look to the handbook and be clear on the documentation for saying, never mind, medication works, whatever it is we anticipated would happen to help sort of clear this person has happened. They are functioning. We no longer think they lack capacity, and we now want the record to reflect that. The next area I want to just briefly touch on is the notion of emergencies, because we have emergencies. We're the VA. We are always having emergencies. And some of our emergencies really aren't exactly emergencies. And it is important to sort of step back. I liken it almost to the stepping back from the table in the OR. I mean, step back, take a breath, figure out what's going on. If we absolutely have a life-threatening emergency, we're not going to run around and try to find an order of priority and who the right people are. We're going to do what makes sense, and we can do that with the chief of staff authorizing the treatment. We're going to do what we need to do if somebody is having a brain bleed or whatever is going on. That's not the circumstances that typically confront us. We are more typically confronted with the sort of maybe emergency that we have 2 or 3 or 5 days, and we need to start digging and find out where family members are, where friends are, who are the people who could be involved in decision-making. Or, on the other hand, what's going to happen in 4 or 5 days? Is this person likely to clear? Are medications going to work? Do we anticipate that for whatever reason, their delirium, their psychosis will start to improve? So it's a shifting sort of clinical kind of issue, but it is not we need to run into court for an emergency. In most states, there is an ability to go into court for an emergency. And we can and we will, and you really need to reach out to folks in one of the regional council offices, and we will help you to navigate to do that. But sometimes what we will also help you to navigate and do is to figure out that may not be what has to happen. And in some instances, we also discovered that there really are family members or friends. We haven't just beat the bushes enough to find them. Finally, the other concern in that arena is too many of the things that play out in our facilities on Fridays are not emergencies. It's just that they're a Friday. And courts get very bent out of shape with that. It's as if we suddenly discovered that we had somebody we were trying to place in a nursing home, and now they don't have Title 19, and so, we need an emergency guardian or emergency conservator. That's not really an emergency, and courts really look askance at us charging in and declaring something to be an emergency. One of the first things several of the judges in New England are quick to do is to look at how long that patient's been hospitalized before the quote-unquote emergency arose. So those would be the important emergency kind of things I'd ask you to think about. I will bump it back now. What we tried to do is put together a case that might provoke a discussion of some of these issues, and I'll bump it back to Dr. Baer or Liz to move us to that part.
Well, thank you. I think Liz is going to help us with the case examples, but I wanted to actually emphasize a point that you made about documentation. And 2 points I'd like to make is, one, once a person has been deemed unable to make informed decisions, that the time to obtain advance directives is over with. And oftentimes I think because there are hospital policies about having people do advance directives, it's inappropriate to have somebody who's been deemed incapacitated to make medical decisions then go ahead and document advance directives. At that point, you really need to be talking with a surrogate, and advance directives have no place. The other thing I think in terms of documentation from health provider standpoint is not just to put in the record that someone has impaired decision-making capacity, but also how you arrived at that decision. What evaluation did you do to determine that? And I would list the questions that you ask and the responses of the patient so that that can be included into the medical record. And quite frankly, that can be very helpful if it comes up at a later point that there was a question about why a certain clinical path was taken, that then you can have that documentation of not only the decision about the capacity, but also how that decision was arrived at. And I think that's very critical, rather than just putting this patient doesn't have decision-making capacity, but put down based on those 4 elements, what elements, based on the questions that you ask and those responses, and how you derive that information. So, Elizabeth, I think you were going to help us with the case examples. And
yes,
because of a short time, I was going to suggest that if our audience does have these case examples, if maybe we could have them read that, and maybe we could respond to questions because of kind of the late start that we had.
Dr. Baer, I think that's a very good idea. And actually, some of you have only scheduled till 4 o'clock in the time that you have available for this call. So the line will remain open until 4:20. Those of you who are able to stay with us. Those of you who aren't, I'm just going to quick do some housekeeping so you have the information in order to get your certificate if you have to leave us now. In order to obtain the evaluation, you'll go to the same place where you got the PowerPoint slides. That's the VA Catalog website at vaw.sites.lrn.va.gov/VA Catalog, and you'll find the links to the electronic evaluation system there. We need you to complete an evaluation no later than February 9th to obtain continuing education credits. When you go to that online evaluation system, you will receive a temporary certificate via email when you submit the online evaluation. However, you must also register in TMS and print your final certificate in TMS. To do that, you go to the Talent Management System, otherwise known as TMS, and you can print out your certificate there. We had an incredible response to this call. It's clearly a topic of interest for many of you. So we apologize for the delayed start, and if you would like to hear all of the presentation, it will be rebroadcast tomorrow at 11 a.m. Eastern. Unfortunately, we overwhelmed the Vance line system today, and that was the reason for the delay. And I would also like to inform our listeners of the next upcoming GREC audio conference on February 23rd at 3 p.m. Eastern, entitled Differentiating Dementia, Mild Cognitive Impairment, and Depression. So at this point, I'm just going to open the lines, as Dr. Baer said, in case you have cases of your own or questions. Hold just one moment, please.
Can I go ahead and ask a question?
Yes, please.
Hi, my name is Bennett Cohen. Yes?
We can hear you.
Okay, I'm a psychiatrist at the Kirkland VA Hospital, and I do tons of consults dealing with decision-making capacity and so on. It's not a case per se, but it's just a general question. We're getting more and more older patients. More and more of these consults are coming in. It seems that they ask for decision-making capacity for any old patient, whether or not there's a real issue. It's almost automatic. So we have to get very specific and firm. But one thing we're also seeing more and more is a question, quote, please evaluate for capacity to, quote, participate in discharge planning. And then when I look into it, what they really mean is it safe for this patient to go home? And I usually end up saying, safety at home is not a unilateral decision or analysis that could be made by psychiatry. We're happy to participate. So I'm just wondering if others have seen that and if my response is sort of the correct one.
Dr. Baer, would you like to start us off with that question?
I appreciate that question, especially as a geriatric psychiatrist. Sometimes we look at an individual and we see that their body fat is redistributed, they're really wrinkly, they may not have much hair anymore, and they look pretty poor condition, and we assume that they don't have decision-making capacity because they look like such a mess. And that earlier study that I referenced was actually done at Walter Reed Hospital, and in healthy elderly individuals, only 2.8% of those had decision-making impairment. Compared with medicine inpatients in general population, regardless of age, it was 26%. So clearly there's really not a direct correlation between age and decision-making capacity. It has more to do with the underlying medical conditions and what else is going on. And I think, what's very interesting to me is when you look at the literature, even experienced psychiatrists or internists that do this quite a bit, when you put all of, let's say, us together in that category, we oftentimes don't agree with each other. And it's led some authors who study this to say that physicians are incapable of determining decision-making capacity because the reliability is so low. So it really interjects a lot of problems, I think, when we try to do that. But I think going through a process, and there's actually a very nice article that came out in the Cleveland Clinic Medical Journal in 2004 that suggested the questions and how to interpret those questions, looking at culture, not just age, but other attributes of patients, that actually walked through some very nice questions and answers that might be of benefit. And it was actually, I think, recommended. It's the Cleveland Clinic Journal of Medicine, Volume 71, number 12, December 2004, and it starts on page 975. That may be of help to help other individuals, especially with discharge planning, really try to wrap their heads around these, because people can use these questions, and then the guidance, I think it does help us become more reliable in between different people who might generate the decision. But also I think it's important to have the attending physicians become integrally involved in this process, and not just kind of as what I call a low spinal reflex. And low spinal reflexes are those things that you actually don't have to have any thinking. It just goes to the spinal cord and then you react. Just to do a low spinal reflex to get a psychiatric consult, I think, is probably not in the best interest of the patient or the care providing team. Does that make sense?
Oh, totally, yes. Thank you very much, and I'll look up that article.
Doctor, I would add, because I can't help but think there's another process going on here. And I think it's also spinal, but I don't know that I would associate exactly what Dr. Barrett was saying. It does have to do, to me, with this notion that we get cover. If we get cover, we call psychiatry and have them give us some cover on this. It is so hard from a legal perspective to keep reminding people, you don't get cover. That's one of the joys of being in the VA. We are all one big, happy family. Nobody gets covered. Nobody's going to look at the record and say, well, I want to talk to Dr. X, but Dr. Y is covered on this one. We are a clinical team. We are a whole bunch of folks who are, at the end of the day, supposed to come up with what was the best the finger pointing comes back to the VA. The VA got it wrong. And we need to stop thinking in terms of if I just pass it to someone else, my piece of this is done.
Great. Thanks.
I think that's a good point. An ancillary of that is patients have the ability, if they have decision-making capacity, to make decisions different than what we would make. And I think we have to really try to be objective with this. And oftentimes we reduce it down to, that's a bad decision. Therefore, they must not have capacity. And that's a very subjective-laden approach to decision-making capacity. So if we come from the point of view that they're not making a good decision, therefore they must not have capacity, we probably need to back up and, again, focus on the process whereby that person made that decision, not just on the decision itself.
Okay.
I have a question.
Yes, go ahead.
Is it possible to get the slides? Not everyone benefited from your original email that had the slides attached.
Absolutely. So the best way to get the slides is the website that I provided. That's the VA catalog website, www.sites.lrn.va.gov/VA catalog. And there you can find us under the title Competency, Capacity, and Consent for Veterans with Dementia.
Thank you.
I have a question. This is AJ Garg. I'm an internist up in South Carolina, upstate. Am I audible?
Yes, go ahead.
Hello?
Yes, we can hear you.
I do home-based primary care, and I run into these situations sometimes. I recently ran into a situation where a spouse requested that patient be seen and his capacity to make medical decisions be questioned. And if he does not have capacity, then she would go to the court to get a surrogate, and then she can put the patient in the nursing home. So I have two questions here. One is, what is the process breakdown from getting a patient deemed incapacitated to getting him to the level of incompetency? The second question I have is, what happens if the doctor judges a patient who actually has the capacity and the team labels him as he doesn't have the capacity?
So that's a multi-point question. Which question should we address first?
First would be that what happens if the patient has the capacity and the team judges it as if he did not have it? What a mistake.
That's probably an issue where there's differences of opinion, and we'll say that different clinicians can certainly arrive at different opinions. In those cases, one of the things that I often recommend to teams is to have an ethics consult and to put out those different opinions and what elements are driving those opinions in a way where they can be discussed within the clinical context to see if that helps resolve the issue. However, what I'm inferring here is that somebody said the patient does have capacity, but the team is acting as if they don't and responding to the surrogate. And I think the comments that Cynthia made and I made earlier about when do you involve a surrogate is only when the person does not have capacity. And I think it's very important if someone does have a surrogate that actually that surrogacy doesn't give them magical powers. For instance, if somebody doesn't want to have something done and the surrogate says, let's go ahead and do that, there may be some feasibility things about that need to be looked at in a more pragmatic fashion. What I'm thinking is if somebody doesn't want to go to a nursing home, for instance, and the surrogate says, I'm going to put them in a nursing home, that could cause some issues that are very complicated and probably require some discussion. What's interesting was there's been a lot of information about surrogates actually not following the wishes of the patient. And I think one of the obligations a surrogate has is to act in surrogacy for the patient, as if they were the patient and carry out their desires. And several studies have shown that when surrogates are asked questions where they know what the patient wanted, but they ask a question, 24 to 30% of those surrogates will actually go against the patient wishes, even though they were established prior to the incapacity. But now that they're incapacitated, the surrogate may not follow the suggestions or the desires of the patient. So this becomes a very complex situation, I think, to look at both the patient, what their previous history was, and how are we going to make, I think I focus on comfort, function, dignity, and quality of life, as well as ability to make the decision. And it's interesting sometimes that those decisions are different than what I might decide just as a clinician alone. I don't know if that made anything. Cindy, would you have anything else to say about that?
Well, I'm thrilled to death that you brought up the notion of an ethics consult, because I think one of the things that Doctor's question gets at is the stuff that often gets laid at our feet, which comes down to sorting through differences with families and with patients about what they want in terms of outcomes. And there is a practical, uncomfortable financial aspect that often goes on at decision-making points for the elderly that absolutely comes down to who's getting the money. And I think that our folks wind up having to pay attention to that and having to pay attention to what the implications are in shifting assets, leading to Title 19 applications, leading to moving somebody out of the house. And all of that stuff is part and parcel of decisions that get put to us. Gee, would you sign this piece of paper? Would you sign this, piece of paper so that I can access my father's medical records? Would you sign this piece of paper, doctor, which basically says my father can't think anymore? We need to pay attention to both what we're being asked, and the other part is, and this is where sometimes it's important for the step back or conceivably the ethics opinion, is that it's important for us to recognize that our primary allegiance is expected to be to the patient. And there comes a point, as Dr. Baer was painting the picture of, the sort of wrinkled, old, not really involved, we're not paying attention. The patient gets lost in some of these processes when we start having conversations with the family, and the family starts telling us what their needs are. Our decision-making is not supposed to be being driven by the family's needs. They are supposed to be being driven by the patient's.
This is Dr. Kavanaugh. I just want to underline just how important it is. I want to come back to this comment earlier about when the team disagrees with the psychiatrist or psychologist's decision about whether the person has decision-making capacity or not. It seems to me that here we have to respect each other's disciplines. In other words, part of my role as a psychologist is to make a decision about whether the person has decision-making capacity or not, and that when I make that decision, the team really has to follow that. We can talk about it, but that's my role to make that decision. And that the team, again, this is frequently an issue. And if you like, if the nursing makes a certain decision about something and the team doesn't like it, the person who's qualified to make the decision has to make it. And it seems to me the team may disagree with me, but it seems to me that that's what I'm here for.
I would disagree with that. This is Bennett Cohn, and no, we're consultants. We offer advice to the primary care team, and again,
I'm a member of the primary care team. It's just I'm psychologist in the primary care team.
Oh, okay, but even still, I think whose ultimate responsibility is it? I don't think anyone has to go with anyone's recommendation in medicine, but the attorney may want to comment on that.
The one thing as a clinician, I'd be interested to see what Cynthia says as well. But as a clinician, oftentimes, and I'm taking, I guess, more of an academic approach, oftentimes when there's differences, it's often because different clinical staff are coming from different data sets. And so I'm wondering if, in my own situation, if they disagree with me, what I'm wondering is have I really educated about my process in making that decision? And in explaining that process, again, it gets back to the documentation of how I made that decision, then oftentimes either they are saying, oh my gosh, I didn't recognize that, or they come up with other information, and it could be that my data set was incomplete as well. So I think when there's oftentimes differences, trying to look at to make sure are our data sets exactly the same, or did I miss something, or have they missed something, and really get into that dialogue of what is the data that's led to this decision.
No, I do take all of that under advisement. The assumption is there's discussion, but at some point, I mean, why would I bother making a capacity decision-making consult if at the end of the day the team says, oh, we're going to ignore that?
Well, I think one of the in most hospitals, and I respect what you're saying a great deal, but oftentimes at that point, if there are very strong feelings for and against, I think that's a perfect setting for an ethics consult and to figure out what's happening there. Because I think the unification of that concept is, for all team members, is very important. And if somebody feels very differently, it's good to get to the bottom of that and oftentimes have a disengaged or outside team member, like an ethics committee, to come in and help sort through some of those issues.
Yeah, and again, I sit on the ethics committee as well, and I know darn well the ethics committee say this is not an ethical issue. This is an issue of team discipline in terms of somebody has to make a decision here, and you're paid to do that, Doctor. Again, in this case, I mean, the team goes along with it. My point being is that there's something to me. I guess what bothers me about this conversation is just because people feel differently. It's a question of what the rationale is behind that, and what's the authority behind that. When the surgeon says, we're going to do this surgery, the team may disagree with that, but it seems to me that you have to go along with what the surgeon. Somebody has to make a decision, and we can talk about it all we want, but at the end of the day, somebody has to make the decision.
This is Deb from Minneapolis. I am also a member of our Ethics Consult Committee, and my question maybe piggybacks on that. But I would like to ask, what are your thoughts on deeming someone as lacking capacity when they have been uncooperative or unwilling with the interviewer for capacity? The thinking here is that since the vet does not want to respond or refuses, we cannot assess, so we must say they lack capacity.
From a legal perspective, that to me would just fly in the face of the presumption of capacity or presumption of competence. I can't imagine a court saying, well, yeah, that's a good idea. If you don't choose to talk, we'll just assume that you're incompetent. I think the assumption would go the other way.
I would have to agree with that, as the lack of cooperation doesn't constitute impaired decision-making capacity. And that, again, is one of those clinically very difficult situations. But I think legally, from what I know and what Cynthia said, that may not be the best clinical decision, is to assume the inability to have capacity just because of non-cooperation.
Thank you. This is Katie from Cincinnati, social work. Am I audible?
We can hear you, Katie. Go right ahead.
Thank you. My question involves surrogacy. Veteran with no decision-making capacity, facing a complicated, serious decision about health care, in this case, the amputation of a limb. He has one son who is incarcerated here in the state and can be reached through the correctional facility. Is he eligible to act as surrogate, or has he lost the right to act as surrogate by way of being incarcerated?
Wow. I mean, you're sort of, for me, pushing the fugitive felon button. I can't always keep up on the ways in which the VA, and this is where I start to get myself in trouble, but the ways in which the VA has us increasingly taking on police functions. But no, I don't believe there is any reason that he is any less able to be a decision-making son because he's incarcerated.
So if someone said to you that he has lost that right by virtue of being incarcerated, you would disagree?
Yes.
Okay, thank you.
I don't. Does anybody
reasonably accessible? I can reach him. I can talk to him.
No, I hear that. But has anybody told you the basis for that loss of rights? I mean,
your conference is scheduled to end in 5 minutes.
I did not think that was a right that you forfeited when you were incarcerated. That's all I was trying to clarify.
Okay, but that's what I'm saying. Nobody showed you some document that says,
no, they just simply told me that I was wrong to.
Yeah, well, my typical position, whenever somebody tells
upon the most. So I think incarceration in no way makes someone necessarily not a good decision maker relative to the parents' issues.
Hello, can you hear me?
Yes.
Hi, this is Dr. Dawn. I'm a psychologist at the Wilkes-Barre VA, and I was wondering if someone might be able to recommend specific psychological test instruments to assess for capacity decision-making.
There have been several studies that have looked, and there are several instruments out there. One study showed that the aid to capacity evaluation, the ACE, was better than another 9 that they compared in a clinical setting. I have to say, though, that most of the research really is looking at capacity on a spectrum or a continuum. And one of the thorny issues is clinically, we're often faced with a dichotomous decision. And so oftentimes these instruments that have been developed really show a spectrum of capacity rather than definitely saying capacity or incapacitated. And so there's still a lot of work to be done in this area, and I think all of these tests that have been measured, such as the ACE, have really been measured against the gold standard, which has been experienced clinicians. Having said that, I also remarked earlier that the clinicians have really been impugned because of the lack of reliability. And so oftentimes these studies are carried out with only 1 or 2 gold standard clinicians because of the difficulty oftentimes of these more complex cases are to really handle. But the aid to capacity for evaluation seemed in at least one study to be a favorable. There's other studies that have used the MCAT, but the one that I've found, at least in clinical applications, the literature supporting most is the aid to capacity evaluation.
I'm glad you mentioned that because I've been looking for information on where to purchase the MCAT, and I have been unsuccessful in finding it with any of the psychological resources.
And it's mostly a research...
Your conference is scheduled to end in 2 minutes.
And we've tried to use that in some settings, but I think it's very difficult in a clinical setting to use.
I should say the ACE...
Other people might have various opinions on that, however.
The ACE is free, I think, and it's online. It's not copyrighted.
Again, the article that I referenced has a list of questions that seem common sense, and it's an outlined algorithm of how to approach this. It's not a test per se, but it does outline questions and how to perceive those questions that might be a good clinical outline, even though you may not get an exact score per se.
Thank you so much, Dr. Bear and Ms. Tyler. This is Liz Archambault, your moderator from VA Boston Grec, and I just wanted to thank everyone who called in today. Again, we would love to have any of you join us to continue this discussion tomorrow. The same call information, 1-800-767-1750, access code 89095#, and we are appreciative of the incredible response today. Thank you again for joining.